This is Aging Forward, a podcast from Mayo Clinic about the science behind healthy aging and longevity. Each episode, we explore new ways to take care of our long-term health, the health of our loved ones, and our community so we can all live longer and better. I'm Dr. Christina Chen, a geriatrician and internist at Mayo Clinic in Rochester, Minnesota. By now, you've likely heard a lot about the GLP-1 medications, also known as glucagon-like peptide 1 receptor agonists. And these are widely prescribed for diabetes and increasingly popular for weight loss. They've also been called life-altering for a lot of people. But what are they exactly? How do they work? And how should we think about these medications, especially as we age? Today, we are joined by Dr. Andres Acosta, a Mayo Clinic gastroenterologist and obesity specialist whose research focuses on the science of appetite regulation, gut hormones, and the complex biology that drives food intake and metabolic health. His work integrates genetics, gastrointestinal physiology, and cutting-edge pharmacology to better understand how we can treat obesity safely and effectively. Welcome, Dr. Acosta.
Thank you, Dr. Chen. Thanks so much for having me. I'm delighted to be here.
To start, can you just break it down for us in simple terms? What are GLP-1 medications and how do they work in the body?
When we eat, our gut sends signals to the brain. So one of these signals that we send is a hormone called glucagon-like peptide, as you said, GLP-1. We have other hormones. And what these hormones are doing are telling us, hey, slow down. I need time to digest. And by doing that, it gives us time to digest the food and absorb those nutrients, but at the same time makes us feel full, so we don't go and find another meal, and it slows down our gastric emptying. So we know this role of GLP-1 and many other hormones for many years, decades. But what's clever and was recently identified is that these GLP-1 hormones will also go to our pancreas and regulate our insulin secretion. So 20 years ago, the first GLP-1 receptor agonist, or the first medication for GLP-1 called exenatide, the brand name is Byetta, was approved in 2006 for the treatment of diabetes. And what we saw with that first generation medication was that a few patients would actually feel very full and lose weight. So subsequently, we had multiple GLP-1s first generation on the market for type 2 diabetes. And then it was Novo Nordisk, the Danish company, who saw that with liraglutide, also known as Victoza for type 2 diabetes, they realized that patients were losing more weight. So they decided to push to higher doses to really push that phenomenon of feeling you full and then showing that these medications will also affect at the higher doses our weight and make us feel full. So how exactly they work? They go to different areas of our brain and affect what is called postprandial satiety.
And what exactly is postprandial satiety?
We just eat a meal, we feel very full, and then with time, we'll start feeling less full, and then we start feeling hungry again. What this medication does is just continue to make you full, so you don't have that return of hunger. A lot of people are now talking that when you feel full all the time, you're not thinking about food. So that food noise is gone. That desire of what you want to eat in your next meal is gone. And even when you come to your next meal, you're going to eat less because you haven't been thinking that much about food. You're not that hungry. So this is how these medications work in different areas of the brain, particularly the hypothalamus, which regulates our appetite sensation, but also in our brainstem, which also connects the gut with the brain.
Like you mentioned, these medicines were originally for diabetes.
Yeah.
And along the way, we've discovered that they have many other benefits too, including cardiovascular health and for the kidneys as well. What else have we found it to be beneficial for?
So let's take it back and look at this historically. First thing we realized is that in patients with type 2 diabetes, but regulating their diabetes and with getting a little bit of weight loss, there was already a cardiovascular improvement. We saw that people who were taking these medications were dying less of cardiovascular disease, which was a very interesting observation and told us that managing diabetes with GLP-1s improve your cardiovascular health, particularly in people who already have heart disease, coronary disease, issues with arrhythmias, and things like that. But also decrease atherosclerosis and the risk of strokes, so cerebrovascular disease, as well as kidney problems. But then came the era of Ozempic. And Ozempic on itself, in semaglutide at Ozempic doses for diabetes, show also the cardiovascular benefits. It's the same medication, but different names for Ozempic for diabetes, Wegovy for obesity. The doses are different for each one of these medications. And then we realized that with semaglutide at the highest doses, at the dose of Wegovy, we realized that people with obesity without diabetes were losing significant amount of weight. So that led to the SELECT trial with people with obesity and without type 2 diabetes. And it was fascinating to see that patients, when treated for obesity with a GLP-1, they had an improvement on their overall cardiovascular mortality with a reduction of 20% of their risk of dying of something related to a cardiovascular event, cardiovascular disease, cerebrovascular disease, or kidney problems. And we also saw that those individuals, which was a cohort of older individuals, lost 10% of body weight. Since then, we have seen a gamut of improvements on the GLP-1s, but a similar improvement that we have seen with other weight loss interventions.
Tell us about those improvements.
If you lose weight, either with a GLP-1 or other interventions, your sleep apnea improves. Your kidney function improves. Your diabetes improves. Your hyperlipidemia improves. Your hypertension improves. Your osteoarthritis improves. Your inflammatory process improves. Your acid reflux tends to improve. So we have so many things that improve. And right now, we don't know whether the improvement is because the GLP-1 medications or because of weight loss.
Right.
But what is fascinating to see is that the same improvement that we have seen with these GLP-1 medications, we have seen with other first-generation medications, and we have seen with bariatric surgery. So until we wait for the jury to come out, I will say that it's weight loss what is driving the most important thing for the improvement of all these other comorbidities. So as I like to explain to my patients, if you have obesity and you have diabetes, hypertension, hyperlipidemia, osteoarthritis or joint pains, sleep apnea, and so on, all these obesity-related diseases, if you lose weight and you treat your obesity, everything else will improve.
Yeah, that makes sense. I mean, we're treating the medically complicated aspects of obesity. And, Dr. Acosta, I'm just curious. GLP is a naturally occurring substance in our body.
Mm-hmm.
So for people who naturally have lower appetite and they don't eat as much or they feel full easily, do they just produce more than someone who is obese and tends to feel hungry all the time? Like, what's the discrepancy?
Yeah.
How come some humans tend to just be more full easily? And is it the amount of GLPs they make in the body?
What we've been able to find from our studies, when we measure these hormones and we measure your gastric emptying and how your gut connects to your brain, we've been able to identify that there are some folks that they actually have a rapid gastric emptying, they feel hungry in between meals, and some of them have low levels of GLP-1. So those people, I call them the hungry gut. It's like their gut's not really responding to the meal.
Mm-hmm.
But that's different from another group of patients, which they actually start eating, they feel full, they need higher amounts of food to feel full. So they want to eat and go for seconds and thirds. Their signal is not telling to the brain to stop eating. So they have more a problem with the brain. I call them the hungry brain phenotype. The hungry brain folks might come to a meal not feeling that hungry. But once they start eating, they want to go for seconds and thirds. They have difficulty stopping.
I see.
They don't have that sensation of fullness. So different characteristics, and that drives our biology. So when you go out there and people are now flooded with ads and social media on the GLP-1s, and all these commercials say it's your biology.
Mm-hmm.
If you have more a hungry gut phenomenon, you're likely going to be a better responder to a GLP-1. But if your biology is more a hungry brain, you're likely not going to respond that well because likely you have a normal functioning of your GLP-1 type hormones.
I see. That's interesting.
Yeah. So different phenotypes and different biology, but drives, unfortunately, to the same outcome. Overeating or eating too many calories, and then gaining weight.
That's fascinating.
Yeah.
So does aging change that? As the body ages and our muscle mass changes over time, do we make less GLP, or does it change our body's response to GLP-1 medications?
I don't think we know. I don't think we know what's really happening with aging and our GLP-1 production itself. But what we do know is that with aging, we tend to decrease how many calories we consume and our sensation of fullness. We feel more full, so we consume less calories. But what's happening during menopause and andropause is our bodies become less efficient, less metabolically effective.
Sure.
So we are just not burning calories that efficient. Despite of eating a little bit less and feeling full with less calories, we are actually not burning all those calories and we're metabolically less efficient. And that's why we tend to gain more weight in the later decades of our life.
So let's talk about the impact of these GLPs because I've seen them really change lives. People lose weight, they feel great, their health issues improve. And so our goal, I think, is to help people get to that healthier weight, to help them reduce their cardiovascular risks, and help them really feel those health benefits. And weight loss, I think, is generally seen as positive, but why can unregulated weight loss be sometimes harmful, especially in the older adult?
Let me say this first. Weight loss is extremely beneficial, not only because of the improvement of the comorbidities. Obesity in itself is an independent risk factor for dying. We know that people with heavier weights tend to live less, about 13 years less than people who have a normal weight. But now, as you were pointing out, everything in life comes with a pro and a con.
And a balance.
A balance. So a risk and a benefit. What happens when we start losing weight? Every weight loss intervention comes with a ratio or a way of losing fat mass and muscle mass. So all weight loss interventions will actually drive some loss of muscle. The most of the times we like to talk in this ratio, for every 2 parts of fat that you lose 1 of muscle. So put it in very simple terms, if you lose 30 pounds, people need to think 20 pounds are coming from fat mass, 10 pounds are coming from lean mass or muscle mass.
Got it.
That is the equivalent in every single intervention that we have seen. Bariatric surgery, previous medications, as well as the new medications. Is a fact.
Okay.
But unfortunately, losing muscle can come with its own problems. And we know that muscle and muscle mass is one of the best predictors of longevity and is one of the best predictors of healthy living, for how long we live and how healthy we live. I think the most important thing that I want to share and I want your listeners to know is we don't know, and nobody does, whether it's healthier to stay at your body weight or lose weight and lose a little bit of muscle mass. And then let me repeat that. Because many people are saying, I don't want to use GLP-1s because I don't want to lose my muscle mass.
Right.
We don't know what's healthier, to stay at your body weight right now or to lose that muscle mass. Because no one has done those studies. Right? But if I can bet, and I can put all the knowledge that I have, and a lot of people will agree with me, it's healthier to lose the weight, reduce your obesity and all these obesity-related comorbidities, and then focus on trying to maintain your muscle mass or regain muscle mass after weight loss. So my recommendation will be, let's acknowledge that as a problem, as a side effect of weight loss, but let's not stop our desire to lose weight and to engage on these new medications like GLP-1s or any other weight loss intervention that will result in effective weight loss.
Yeah. That's a really good way of framing that because we want to achieve healthy balance in both, ideally.
Yeah.
So if you are losing weight, how do we do it in a way where perhaps a third of the muscle mass is not lost?
Yeah.
And do it in a way where we preserve that and lose all of it as fat.
Yeah.
Aside from obviously becoming weak with muscle mass loss as a result of rapid weight loss, what are some other complications that we typically see with sarcopenia, the loss of muscle integrity?
So sarcopenic could be with obesity or without obesity. You can have a normal weight patient. We see that people with sarcopenia have low muscle mass. That's a fancy word for low muscle mass. They tend to live less and they have more frailty. They're not that strong. So strength is one of the important measurements of long-term longevity and overall mortality. So, a good example that I have seen a lot in my clinic, patients come and they lose 100, 140 pounds, extremely successful weight loss-wise. But then when I do a body composition, they still have 30 to 40% of fat mass. So despite of all the weight loss, they still preserve a lot of the fat mass. So even when you might be looking yourself in the mirror and saying, my weight looks normal, you may still have a higher percentage of fat mass and a low percentage of muscle mass. And that is still not healthy. So as I like to explain to my patients, when we try to reach for optimal health, a normal body weight is a good first step. But then we need to think about your percentage of muscle versus your percentage of body fat. And we need to try to keep a high percentage of muscle mass because that is the key for health and for longevity. And why this matters? Because if you have more muscle mass, you'll be able to walk longer. You'll be able to walk faster. You'll be able to lift out of the chair. all these things that really matter, you'll be able to enjoy more life. Because if you are playing golf, you'll be able to walk those 18 holes or play a full game of tennis, right? When you have more muscle mass than when you are a little more frail.
Right. I have observed in some patients where they lose the weight. On the scale, the numbers are lower, but then they're developing issues like musculoskeletal pain or neck pain or more joint pain. And sometimes I wonder if it's related to what you explained earlier. Are we losing some of the support structure to help those joints stay intact and strong and mobile? Because if you are already in this situation of a sarcopenic obesity, meaning we've got larger body mass, but very little of it is muscle mass to begin with, and you lose more, then it can impact the joint health. And sometimes I wonder are we causing more joint issues?
We haven't seen that kind of data on the studies that we're looking at joint issues or arthritis or joint pains, but it's very possible. And it's very possible that with the weight loss, we might be causing some side effects or undesired. What I like to explain to my patients, though, is when they're experiencing these side effects, we need to separate why we're experiencing the side effect. Is it because you've been losing weight for a long time and you have been depriving yourself of important nutrients and enough protein? You are maybe not well hydrated because when you're feeling full all the time, you don't even want to start drinking water.
Right.
So I like to first do a good check on my patient, hydration status, nutritional status, and then their strength and overall performance, to make sure we're not overdoing it, right? Because going to the other extreme of the pendulum, which is underweight and malnourished and with low muscle mass, is as bad as obesity. So both extremes are bad. We need to try to stay on the middle and stay healthy.
Yeah. That makes sense.
Yeah.
How about in the oldest old category, meaning 85, 90 and above? Do you have patients in that category where they want to lose weight, they've been overweight their whole life, and are there risks in that age group?
It's always a population that we are a little bit more careful.
Yeah.
I've had a few patients, not many, that have come in these populations. And one of the first things that I like to set up in all our patients, particularly in the 70, 80 decade, and even in the 9th decade of life, we like to set the right expectations. They're going to lose less body weight. So for example, if we look at the SELECT trial, there was a population of individuals older, they only lost 10%. They didn't lose the 15 or 20%. But what is extremely important in this population is that we need to preserve their physical activity and their functionality. So in these cohorts of people in the 80s and 90s, I really try to encourage them physical activity, exercise, and resistance training to preserve that muscle mass.
Yeah.
At the same time, I like to remind them that most likely the reason why they're living to their 80s and 90s is because their metabolic disease hasn't been that predominant or severe. Likely they didn't have developed early diabetes in their 40s and 50s, right? So I like to say we need to focus on muscle mass, weight loss, but not be the whole culprit of it. So more conservative weight loss and very closely monitor their nutrition intake, their nutrients, their caloric intake, their liquids intake, and their labs to make sure there's no metabolically dysfunctions.
Yeah, that's true. If someone's living into their 90s, I mean, they've got longevity as a benefit already. And now they're wanting to improve their health span even more, to live better days. And how do we use these medications thoughtfully to help them achieve those better days?
Absolutely.
Right?
Now, and it's important for your listeners to know, all the studies that are quoting the benefit of these medications did not include people older than 65. And there are very few of them included people older than 65, but only up to 75. So it's an area that we don't know a lot. That's why we want to study and answer that question, because it's important to know, first, if it's safe.
Right.
And is there anything else we need to be looking out for?
Yeah.
So more studies needed in the space. But I will always advise that if any of you wants to start a healthy lifestyle, adopting more exercise, more physical activity, and weight loss, do it under medical supervision if needed, and do it slowly. Don't think tomorrow you're going to start running marathons again.
Right.
Start by walking, increasing gradually, then pick up some physical activity in the form of resistance training, and then eventually think, if not, want a medication or something else, or some other intervention.
Yeah. Let's talk about BMI for a second here, because as a geriatrician, I'm always on the alert for signs of undernutrition. I think that's sometimes overlooked, is when people start to not eat well and start to become undernourished. And the main thing that we look at is their degree of weight loss, usually unintentionally. So we see like 5 to 10%, greater than 10% weight loss in 6 months' time. That's an alert for us to say, okay, something is concerning there. So as far as BMI targets for older adults, how do we balance the risks of GLP use and the risk of malnutrition? And what's that target that you're looking for?
So I like to discuss with my patients what are their goals and set up what are the right expectations for their goals. So if someone in their 70s and 80s tells me, I want to be my weight that I was when I was in high school, I will say, let's be more realistic with our goals. But I still try to encourage them to increase their overall health, particularly in the younger 70s, because we know they have 20 more years of life, if not more. So setting up the right expectations and then thinking that we're going to do this under medical supervision. So they shouldn't do it alone. First, we need to know what is the expected total energy expenditure in a day and create a caloric deficit. I like to say that we should start with a caloric deficit of about 30% of their calories, but that needs to be tailored to their individual needs. If it's someone who is already fragile, who have many comorbidities, for example, have type 2 diabetes on insulin, have to be careful when I decrease their caloric intake. But if there is no comorbidities and they're pretty much otherwise healthy, they just want to lose a few extra pounds, I'm going to monitor labs and then I'm going to put them on a restrictive diet. And I'm going to monitor that. I'm going to really make a big emphasis on protein. So at least 1 gram per kilogram of body weight, at least. Ideally 1.2 and somewhere in that range between 1.2 to 1.5 of kilograms per body weight. So protein is key. In any individual, I will recommend resistance training. Preserving muscle mass is key. And if you want to do that now in combination of a GLP-1, it's extremely important that I counsel to my patients the big risk of nausea and vomiting. We know that depending on the study, 60 to 80% of patients will report nausea or vomiting. And if it's a patient, for example, a patient who already has kind of weak kidneys or chronic kidney disease, I need to be extremely careful of inducing nausea because I know they will not be drinking and eating enough. And that can lead them to hypotension, hypovolemia, further damage of the kidneys. Unfortunately, that happened to one of my patients. I started one of these medications. The patient felt so nauseated, could not eat or drink anything for a day, ended up in the emergency room with dehydration and acute kidney injury on top of his chronic kidney injury. So we just have to be very careful and monitor our patients and think that time is our friend. There's no need to rush. Some people took 20 to 30 years to get to the weight that they are right now. Some people took 50 to 60 years to get to the weight that they are right now. Let's not think we need to solve this problem in 3 months. If it takes us a year to get to a healthy weight or 2 years, that's perfect. And I like to invite my patients to the weight loss journey. And I said, we're going to start a journey. Maybe start with a diet alone. You want to start GLP-1? Great. Why wouldn't we start with diet and see what happens? Let's start some exercise. And then if we don't think that's enough, we can bring a GLP-1. And all that can be under monitoring, checking their labs, make sure they have enough nutrients, particularly minerals and vitamins. And under good supervision, we can use these GLP-1s and all obesity interventions and help our patients achieve successful weight loss and help them in their journey of a healthy weight and healthy living.
Yeah. What I'm hearing is that we really should be guiding patients and being part of the journey with them together and giving them clear expectations, having the conversations over and over again. It's not just, here's your regimen, good luck. Hope your weight loss journey goes well. And that's my fear, is that as this becomes more popular and more mainstream, that you're able to get it easily without that provider partnership where you're talking to them about your protein intake and the resistance training and all those important goals and expectations, because that's how we achieve the best outcome afterwards.
Absolutely, Dr. Chen. I think the same way we do any other chronic disease, hypertension, diabetes. But we also recognize that providers, particularly primary care doctors, are super busy. So sometimes we don't have the opportunity to maybe meet with our patient once a month to see how things are going. And one option is to seek a practice that actually has a multidisciplinary group that can have a wellness coach, registered dietitian, physical therapist, or behavioral psychologist. But there's also a lot of commercial programs out there that can support the decisions of your providers. So for example, at Mayo Clinic, we have the Mayo Clinic diet. We decided to pair the Mayo Clinic diet with the GLP-1s in a new program called the Mayo Clinic Diet Companion Program. And our patients can either buy the book if they want to learn by themselves or sign up for the commercial program. And then they can go and read and then get the support from the team online to guide them in this journey, particularly when they start GLP-1.
Mm-hmm. Yeah, because it really is a lifestyle change. It's not just a medication that you're adding to the regimen. It's a complete change of routine and
Absolutely.
how you view what you're eating and how to eat
Absolutely.
better. Yeah, that makes sense.
It's such a drastic life change that there's a lot of already reports about how it changes your dynamic with your friends and with your significant others. Because if you think about it, a lot of the things we do is around food.
That's true.
So if you're suddenly invited to a large party and a big meal and you only have a few snacks, they might not want to invite you again. It's like you might seem a little bit rude. But the reality is that you are actually under a medication that is going to make you very difficult to overeat. So it changed a lot of the dynamics with your family as well. So all those things is changing, right? But it's changing towards a healthy you, a healthy lifestyle. So why not embracing it, right? And bring everyone else on board.
You talked a bit about the side effects of GLP-1s earlier, which is some of the nausea and the queasiness and just general gut problems. Are there any other side effects to be aware of or complications of these GLP-1s?
Yeah, so there are contraindications to the medications,
Yep.
particularly people with medullary thyroid cancer or a family history of medullary thyroid cancer. There is also contraindications in patients that had a recent history of pancreatitis. There is a potential risk of developing pancreatitis, even though the data has not supported that. And there's other GI side effects. Diarrhea and constipation is common. People who are losing weight can have more gallbladder issues, so the forming of gallstones and then gallbladder attacks. And then some people might get developing worsening GERD because of their acid reflux being worsening. So those are the things that we watch for and we advise our patients on.
How about medication interactions? Because a third of older adults over the age of 65 are on 5 or more medications. Are there specific polypharmacy concerns or medication interactions we want to be aware of?
Yeah, absolutely. And not really because these GLP-1s, particularly liraglutide, semaglutide, and tirzepatide, interact with other medications, but because what might happen when an individual starts eating less and drinking less. So when that happens, you're going to start losing weight. And for example, if you're on insulin or sulfonylureas that will lower your blood sugar, you're at higher risk of hypoglycemia,
Sure.
of low sugars. And low sugars can kill people. So that's why we are very careful. So if you're on insulin, this needs to be managed by a professional. We also need to be aware that when you start losing weight, your blood pressure improves. So if you're taking 2 or 3 blood pressure medications, suddenly your blood pressure is going to start coming down on itself. So you're going to feel lightheaded. You might have risk of dizziness and even syncope events. So someone needs to be monitoring your blood pressure and taper down the medications. Same thing with pain medications. You might be feeling less joint pains, back pains when you're losing weight. We need to make sure you're taking less of those medications. So we need to start tapering down the medications. And examples like that, there are many. That's why I'm saying this is to be done under supervision.
Sure. If anything, that's a good opportunity to get rid of things that you've been on for maybe 10, 20 years. You've been on 3 blood pressure medications and you can start to simplify.
Absolutely.
Yeah.
And that's one of the things that I tell my patients and they love the most is they come and see me with 5 or 6 medications and say, hey, when we get you to a healthy weight, you might not need any of those medications. So it's a huge win of obesity and weight management. It's like, just get rid of all these other comorbidities and all these medications, all these comorbidities.
Yep.
And then it comes with a question that I get all the time. Doc, for how long will I have to take this obesity medication?
That was my next question for you. Yeah.
And I like to say to them, well, let's get rid of all these other medications you are taking for obesity-related diseases, and then we'll take you off the obesity medication.
So have you seen any success with that? When people are on a GLP, say for a year or 2, are they able to get off of that eventually?
Yeah.
Okay.
So diabetes is the first ones we get them off.
Yeah.
So if they come on insulin, we immediately get them off the insulin once we start losing weight and with a low-calorie diet. Then we start taking the other medications out. Then we usually titrate down the blood pressure meds. Blood pressure is not always something that we're able to completely take off, but we can always come down on the medications. We can reduce the doses of the hyperlipidemic medications or the statins. We can reduce the doses of the pain medications. I usually even taken off things like medications for chronic pain, such as gabapentin or Lyrica, which actually makes you gain weight. And if you're taking those medications for joint pains, you take a medication that helps with your pain but makes you gain more weight, it's actually making you have more pain. And then some people then stop needing to use their sleep apnea machine. So all these benefits because of weight loss.
Yeah.
And what I tell them is we're going to take care of all these things, see if you need them or not. And then the last thing we'll try to get rid of is the obesity medication.
Yeah, because I think in mainstream media, the common message I've been hearing at least is that once you're on the GLP, you need to be on it forever and that you can't come off. Or when you come off, you're going to probably gain the weight back or you're going to get the symptoms back. And I think that's how the general public right now at least understands it.
Yeah, that is partially true. But yes, there's multiple studies that shown that with any anti-obesity medication, GLP-1s or the others, if you lose weight with one of these medications, as soon as you take it off, you start going to regain your weight. But let's be critical about those studies.
Yeah.
Those studies, you were abruptly taken off the medication. So what we're doing now in the clinic is we're slow tapering down the medications. By doing a slow taper, I want to see whether we can actually reset the biology. We have this set point that tells us when to feel hungry, how much to eat when we feel hungry, right? And my hope, and hopefully studies will be supporting this, is that when we start tapering down these medications, we'll have patients who do not have hungry gut, who will be able to come off of these medications because that was not their biology. But we'll have patients who do have the biology who might struggle with coming out of these medications. And those patients, because of their biology, might have to stay in there for life. So my hope is that in the future, we'll be able to have evidence and data to support who cannot stay for very long times and who will actually be able to come off. And those who may stay for long times, I want to change the concept of you may not need to be on a GLP-1 as weight loss medication, but more for a weight maintenance. And maybe you only need to take a lower dose, maybe a weekly dose, maybe once every other week or so on. As we call it, a maintenance dose. A little bit like we have done in cancer, right?
Yeah.
With cancer, we have induction medications really hit aggressively. And once you're cancer-free, we put you on this maintenance dose to prevent cancer recurrence. Same thing here.
Got it. Would you consider anyone, I guess, a poor candidate for these GLPs if there's certain criteria where you just feel like this is going to cause more harm than good?
Yeah, I'm very careful with patients who have strong history of eating disorders and they are barely borderline to qualify for these medications. And many of them are actually seeking these medications despite of not having clear criteria, meaning a BMI greater than 27 with comorbidities or BMI greater than 30. And unfortunately, that's one of the risks of compounding pharmacy. And a lot of these companies selling these products without really following all the FDA guidance. You can have someone who do not meet criteria, who can still access them just for pure aesthetics purposes or for overusing. And that will be concerning. I'm also concerned when a patient comes and have a long history of type 2 diabetes, already with signs and symptoms of gastroparesis, of their stomach not working well, being very slow, and they feel very full. That if I'm going to start these medications, I might make that worse because these medications are also slowing down our gastric empty.
Right.
Additionally, I am always careful when I'm thinking about an injectable in patients who might be already very frail, or they may have a risk of hypoglycemia if they're taking very high doses of insulin. So those are the conditions that I'm a little bit careful. And as I said before, patients with a recent history of pancreatitis, I'm very careful as well.
Do you know what's in the future, Dr. Acosta? We've made so much advancement over the years, but in the next 5, say 10 years, what's the future of these GLPs going to look like for patients? Will they be more accessible?
So I think in the space of access, unfortunately, we have seen that the medications are not covered by insurance. Less insurances as private insurers are covering, and Medicare continues to put a lot of restrictions to patients, particularly those who want to lose weight because of obesity. And the cost, even though they have come down, are still very limited to a few patients who can afford more than $350 per month. So we need solutions for that. And depending which one you have, we can tell who should go to a GLP-1, who should go to other first-generation medications, and everyone loses the same amount of weight, making obesity management more cost-effective, but also telling the patients whether they should really be on these medications or there's a more affordable option for them, because both first-generation medications are about a third of the cost of the GLP-1s or even less. Some of them are generic and cost $40 a month. So access and utilization of the meds in the right way for the right patient is key. And we have this solution that we're offering to treat the biology of the patient, who solves both problems. Then we're also going to have more medications. So the pipeline for weight management is extremely rich. There is, depending which report we read, more than 100 medications right now on human trials with different combinations. These are GLP-1s, but there are many hormones our body's making. And now our pharmaceutical companies starting to play in with how you combine these different hormones that are all coming from our gut to enhance their outcome. So we have now glucagon medications coming in dual agonists, GLP-1 glucagon. We're going to have a triple agonist, glucagon, GLP, GIP. And then we're going to have medications that help us build muscle mass, which will be hopefully ideal for patients who are concerned about that losing muscle mass and longevity and frailty. And then we'll have other types of medications. So the pipeline is extremely rich. But finally, I think it's also important to understand how we manage these side effects.
Yes.
So it's extremely important that we find protocols and understand how do we avoid the nausea, how do we avoid the muscle mass loss, and how do we really try to reach health. Because when we're treating obesity, we're treating all those obesity-related diseases, we're really trying to prolong life and actually reduce our risk of our overall mortality and also live healthier.
Yeah.
So I think that's where we need to also think that there will be just not the GLP-1s and the obesity medications we need to focus, but we need to focus about other things. We cannot forget the importance of food and eating healthy and nutritious food, and also about physical activity and exercise.
And that beautifully ties into my last question here is, at a high level, ultimately, how do we define success with these GLP therapies?
So every single patient that I've seen in the clinic for the last 15 years came out with their own metric of success. The majority of them have a number that they want to achieve because they realize that at that number they were the healthiest, but they also have another reason. And, it breaks your heart when you hear people saying, I just want to be able to climb up the stairs behind my kids and be able to crawl down and play with them.
Yeah.
I want to be able to run behind my grandkids and play soccer with them, or be able to throw the ball and play catch with my son. I just want to be healthy, right? And that definition is so unique because even though we try to define what's health, it's still your own perception, right? It's still how you feel healthy. But I can tell you that the majority of my patients and the people that I talk about this have their own definition of health. Usually it comes up with some sort of healthy weight, but also with no comorbidities, but also with physical activity, right? With exercise. But then that meets reality. Reality is that if you're coming, 250 pounds, 300 pounds, with most of these interventions, even with bariatric surgery, you might not reach those numbers. So we need, as I said before, multidisciplinary team with multiple therapies, combination therapies, and be patient because it's going to be a journey. But in a journey, I have many patients who have achieved that goal. And a good majority of them do. But they don't do it in 6 months. They don't do it in 3 months. It was like this, and I did my New Year's resolution, and by March, I'm already at my health. No, it takes time. It's going to take a year, 2, some even more, 3 or 4. I've been following a patient now for almost a decade. And this very pleasant individual has lost 155 pounds.
Amazing.
Without any medications, diet and exercise. And now we're looking for improvement of percentage of muscle mass. Now we're looking about healthy eating, because there was a lot of things that he was eating a little bit of, but enough for us to say, that's not very healthy.
Right.
So let's keep pushing for that boundary of ultimate health, which we all pursued, and I think is a forever pursuit that I wonder if we all will reach, right? But it's what we need to always aim for.
Yeah, it's very true.
Yeah.
We have one last question. It's kind of a closing tradition question is, how do you personally age well? What do you do personally in your life to do that?
So I start by eating food. I eat very little processed food. And if I can eat organic when I can, I do that. So I also think that we need to eat the right amounts of food, because even healthy food at the wrong amount is not healthy. And I'm a big proponent of physical activity and exercise. So we should all be exercising, something that you like and enjoy. Because exercise should not be, I painfully need to exercise because my doctor told me, but it should be because you enjoy it. So I enjoy going out on bike rides and running and resistance training. And then finally, it's essential to have your family, your friends, and your community. Because support systems are key to have a healthy aging and a healthy living. So it's not only about aging, but also living.
Absolutely. Well, Dr. Acosta, thank you so much for being here. It's just such an honor to be able to share that conversation with you today. And I hope that from this conversation, we can really understand that the key is really individualized care for each person, really understanding their goals, asking the right questions, balancing the risks and benefits, and really partnering with your right provider to make this as accessible as possible. So thank you again for this conversation. It was wonderful.
My pleasure. Thank you so much for having me.
So that's all for this episode. Hopefully you're feeling a little bit more informed, inspired, and empowered. If you have a topic suggestion for a future episode, you can leave us a voicemail at 507-538-6272, and we might even feature your voice on the show. For more Aging Forward episodes and resources, head to mayoclinic.org/agingforward. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, stay curious and stay active.
This podcast is for informational purposes only and should not be relied upon as medical or legal advice. Always consult with a qualified healthcare provider for any medical questions. The appearance of any guest does not imply an endorsement of them, their employer, or any entity they represent. The views and opinions are those of the speakers and do not necessarily reflect the views of Mayo Clinic. Reference to any product, service, or entity does not constitute an endorsement of or recommendation by Mayo Clinic.